Welcome, everyone. Thank you for joining us for today's EMARS webinar entitled Impact of Estrogen Deficiency on Quality of Life in Asia and the Role of Continuous Combined MHT in Treatment. We are delighted to have you here. My name is Professor Petra Stute. I'm the Vice President of EMARS and I'm from Switzerland. Before we begin, I have a few organizational points. The webinar is simultaneously translated into 5 languages, so please choose your preferred language. If you have any technical issues during the webinar, please let us know via the chat function. For content-related questions, please use the Q&A section. The recording will be available soon. This Friday and Saturday, we will also have EMA School, so please register. And the next conference in person will be in Valencia in May 25. Registration is already open and abstracts can be submitted. I will briefly introduce each speaker before their presentation, and each presentation will take 20 minutes. After both presentations, we will move on to the discussion session, and this webinar is sponsored by Abbott. So this being said, we look forward to an engaging and insightful session. So let's get started. It's a great pleasure for me to introduce to you the first speaker. Dr. Dayong Lee is a specialist in reproductive endocrinology with a major focus on the management of menopause and fertility preservation. Dr. Lee has held roles as a clinical fellow, assistant professor, and clinician at leading medical institutions. His current position is at Seoul National University Borame Medical Center. Dr. Lee is also actively involved in academic societies, such as the Korean Society of Menopause and the Korean Society for Fertility Preservation. And he is going to talk about trends and characteristics of MHT in Korean Asian population. So thank you very much, and we are very excited to have you here.
Thanks for the introduction. It's my great honor to present here about the trends and characteristics of MHT in Korean population as a member of Asian countries. I have no CY to disclose. As a healthcare profession in reproductive endocrinology, I've noticed that the practice on MHT in Korea differ from those observed in the US, European countries, and even neighboring Asian countries. I've been curious about the reasons behind these differences. Could it be due to differences in the efficacy or side effects of the medication used, or are social, cultural, and economic factors at play? Several studies that shed light on these reasons have been published recently, and in this presentation, I will review these findings. This study analyzed the use of MHT in Korea following the publication of the WHO study results. Korean government operates a National Health Insurance Service, NHIS, and all citizens are mandatory to enroll in it. According to the prevalence of MHT use, in 2002, only 7.8% of women greater than or equal to 40 years used MHT. And this was much lower than those observed in the US and Europe. It is well known that Asian women experience purer and shorter duration of vasomotor symptoms compared to other ethnic groups. Following the publication of the WHO study results, the use of MHT among these women decreased by 18.8%. During the period, the overall consumption of MHT medication decreased by 54.7%, and this decline was evaluated after 2006. In this graph, the user ET is reported to be about twice that of EPT. This is because Tibolone is included under ET in the ATC classification system by the WHO, but actually Tibolone does not belong to ET preparations. And this error was observed because Tibolone is the most commonly used MHT preparation in Korea. Looking at the drug usage by age, we can see that the proportion of people in their early and late 50s is the highest. The proportion of people in their late 50s has been increasing steadily recently, and I assume that this reflects the tendency to start MHT before the age of 60 according to the timing hypothesis. The Japanese data on the right, which includes more recent data, better illustrates this trend. We can see that the drug consumption of non-oral MHT in Korea is significantly lower compared to oral formulations, with the medication consumption being only about 1/10 of oral formulations. During the 11-year follow-up, about 70% of women were prescribed MHT for less than 1 year, and only about 12% had a prescription for 3 years or more. In Japan, we can see that the percentage of individuals who continue MHT for more than 3 years is around 10%, which is similar to the data from Korea. When summarizing the trends of MHT in Korea, the prevalence of MHT use remains relatively low in Korea, so only a few selected EPT medications survived. Among MHT formulations, Tibolone is the most commonly used oral preparation in Korea. And the usage rate of non-oral MHT in Korea is significantly lower compared to oral formulations. In fact, only a few selected MHT medications are available in Korea, and this table presents the recent EPT formulations that have been introduced. And among them, only these medications are currently available for prescription, so very limited EPT can be considered in Korea. The progestins included in these medications are dihydrogesterone, cyproterone acetate, and drospirenone. Estrogen only and progesterone only formulations can be used like this, and in addition, step formulation and Tibolone are also available. Among them, transdermal estrogen and steroid formulations are not covered by the Korean health insurance system, adding financial concerns for both clinicians and patients. These characteristics of MHT in Korea have raised me two questions. The first is why transdermal estrogen is not popular in Korea. Is it because its effectiveness is lower, or simply because it's more expensive in Korea? The second is there evidence that the currently used MHT formulations in Korea are better in terms of safety regarding the breast cancer and cardiovascular disease for Korean population? And now I will organize the recent data on these questions. To address the first question, I will review studies on the efficacy of non-oral MHT in Asian population. Recently, numerous articles in the Europe and US, including reviews and expert opinions, have highlighted the advantages of the combination of transdermal estrogen and micronized progesterone. The advantage of this drug combination is that it does not increase and may even reduce the incidence of venous thromboembolism, cardiovascular disease, and breast cancer. This study retrospectively compared the efficacy of tibolone and transdermal estrogen in Korean women. Tibolone was chosen as a comparator because it's the most commonly used MHT formulation among Korean women. The daily dose of 1.5 gram of transdermal estrogen gel was used, as this is considered the standard dosage in Korea. After 6 months of use, transdermal estrogen formulations demonstrated the advantage of a low BMI compared to tibolone. However, when comparing the menopause rating scale MRS scores, the differences were observed between the two formulations. But this study has some limitations. It's a retrospective analysis and included only 26 and 31 women in each group, which is too small. So prospective large-scale studies are further required. To address these limitations, recently a Chinese research group published the result of an RCT involving 257 women. The study compared 2 milligram of oral estradiol valerate daily with 2.5 gram of transdermal estradiol gel daily. Therefore, this Chinese study used a much higher dose of transdermal estradiol compared to the previous Korean study. Although there was no differences between the groups in the Kupperman menopausal index after 24 weeks of treatment, the oral formulation had a better effect on the menopausal rating scale when treatment was continued for than 12 weeks. The serum FSH and E2 levels did not significantly differ between the two groups after 24 weeks of treatment. However, serum estradiol levels in the transdermal group were slightly lower than those in the oral group, and FSH levels were slightly higher in the transdermal group. Looking at the table on the right, comparing the adverse effects between the two groups, there appeared to be no significant differences between them. Therefore, based on the results of this RCT, it can be concluded that relatively high dose of transdermal estradiol would be needed to achieve effects similar to those of oral estradiol in Asian women. Based on these research findings, I thought that the low usage of non-oral MHT in Korea can be explained. It can be inferred that the standard transdermal estradiol gel dosage used in Korea may be insufficient to evaluate women's vasomotor symptom effectively. However, when examining the MHT practice data from Japan, a different trend was observed compared to Korea. In Japan, the proportion of the population using transdermal estrogen for the first MHT regimen was about 20% in 2006, but by 2021, this had significantly increased to 66%. This suggests that the advantages of transdermal estrogen have gained social consensus in Japan, leading to its widespread use. Therefore, it can be inferred that the low usage of transdermal estrogen in Korea is influenced by factors beyond just the efficacy of the medication, suggesting that other various factors play a role. As discussed earlier, in Korea, transdermal estrogen formulations are not covered by the national support, making their maintenance cost relatively higher compared to other MHT medications. Another factor is that Koreans tend to prefer more convenient medications, so they may find it uncomfortable to wait for the gel formulation to be absorbed through their skin. So this would be the summary for the first question, why transdermal estrogen is not popular in Korea. Considering existing Chinese RCT, achieving effects similar to oral estrogen in Korean women may require higher dose of transdermal estrogen than expected. Though in Korea, there is a lack of data on the effective and safe dose of transdermal estrogen. Due to this insufficient data, the Korean government has yet to provide national health insurance coverage for this type of medication. This practice would create a vicious cycle, resulting in significantly lower use of transdermal estrogen in Korea compared to neighboring countries. To break this vicious cycle, well-designed prospective clinical studies targeting Korean women will be necessary for the future, I think. Next, I review the data related to the second question, real-world outcomes of safety of MHT in Korea. It is well known that the incidence of breast cancer in Asians is lower than in the US or Europe. However, Korea, along with Japan, has the highest incidence of breast cancer in Asia. In Asia, breast cancer tends to occur more frequently in younger women, and this trend is particularly pronounced in Korea. According to Korea's breast cancer registry data, 66% of women diagnosed with breast cancer are in their 40s and 50s. This suggests that the characteristics of breast cancer incidence in Korea may differ from those in Western countries. Moreover, since women in this age group are the primary candidates for initiating MHT, the safety about breast cancer is a critical issue. This year, a Korean researcher analyzed the correlation between MHT and breast cancer using the NHIS database. The study showed that Tibolone and ET did not increase the risk of breast cancer. However, combined EP therapy by the manufacturer CPM, currently available in Korea, were found to increase the risk of breast cancer. Additionally, the study revealed that the prevalence of Tibolone use in Korea is high at 47%. On the other side, the use of EPT containing micronized progesterone is very low for now. When analyzing based on the duration of MHT use and the observation period, the risk of breast cancer tended to increase with prolonged MHT use like this. In this study, the use of dihydrogesterone was generally associated with an increased risk of breast cancer. However, while other types of CPM showed an increased risk of breast cancer with long-term use like this, CPM using dihydrogesterone demonstrated a decreased risk of breast cancer with prolonged use. Therefore, CPM using dihydrogesterone may be superior to other types of CPM in terms of breast cancer risk. In most MHT formulations, an initial increase in breast cancer is observed in this data, and this may be influenced by various factors such as early detection or progression of pre-existing breast cancer. So, well-designed prospective long-term data collection on dihydrogesterone as well as micronized progesterone would be further needed in Korean population. Indeed, representative cohort studies in Europe has demonstrated that dihydrogesterone exhibits superior safety compared to other progestins. This may explain why European and Chinese research groups chose dihydrogesterone in their ultra-low-dose EPT trials. Therefore, I believe more reliable studies would be needed also in Korea to confirm the safety profile of dihydrogesterone. The same Korean research group also analyzed the correlation between MHT and cardiovascular disease CVD using this NHID database. the study reported that the use of tibolone was significantly associated with the increased risk of CVD compared to CPM formulations. The increased risk appeared to be primarily due to rise in stroke incidence rather than myocardial infarction. The study also found that the risk of CVD increased with longer duration of tibolone use, even when the medication was used at half the standard dose. This suggests that given the high prevalence of tibolone use in Korea, careful attention should be paid to the potential risk of CVD. In this study, an increased incidence of stroke was reported among transdermal estrogen users. Since this formulation is not covered by national insurance in Korea, physicians will choose this medication for women with higher CVD risks. Therefore, this factor may act as a potential bias in the study results. In this study, moreover, CPM formulations were not found to increase CVD risk. However, variations in outcomes may exist depending on the types of progestins included. Therefore, further research in Korea is warranted to explore these differences. To summarize the answer to the second question, in Korea, the use of tibolone does not seem to increase the risk of breast cancer, even with long-term use. Regarding the use of dihydrogesterone in Korea, data is insufficient to confirm whether its use does not increase breast cancer according to the duration. So additional safety data on dihydrogesterone and micronized progesterone should be further investigated. Tibolone is the most commonly selected MHT formulation in Korea, but regardless of the dosage, there is a potential risk of increasing stroke with prolonged use. So further research is needed to determine if there are differences in CVD risk based on the progestin component of EPT in Korean population. In conclusion, the use of MHT in a specific society would be influenced not only by the drug's actual efficacy and safety, but also by social cultural factors in the society, such as physicians' preference and national support systems. Large-scale representative studies on the efficacy and safety of MHT have primarily been conducted in the US and European countries, and recent studies conducted in Asia suggest that the effect and safety can be different from those observed in Western populations. So collaborative studies and sharing of clinical data involving Asian populations will be necessary for the future, I think. Thanks for listening.
Okay. Yes, thank you very much, Dr. Lee. This was a very interesting presentation. I've already gathered it. And I would also like to encourage the audience to send questions into the Q&A section so that we have a lively discussion afterwards. And before we actually start with the discussion, we will have first our second presentation. And the second presenter is Professor Dr. Hugh Shi. He's the past president of the Menopause Federation. He's the current Chinese Menopause Society and the Chinese Society of OBGYN. And he's a professor of the Center of Reproductive Endocrinology and Reproductive Medicine at Peking Union Medical College Hospital in China. And he's going to talk about the efficacy and safety of ultra-low-dose estradiol formulations. So, Professor Shu Hui, Welcome, and we are very happy to have you here, and we are looking forward to your presentation.
Thanks, Petra, for your kind introduction. And now I share my screen. Okay, the topic of mine is the efficacy and safety of ultra-low dose estradiol formulations. I'm Yu Qi from Peking Medical College in China. So this is the guideline of what I will say. And the first part is the guidelines recommended the lowest effective dose of MHT, menopause hormone therapy. The guidelines, including the 2016 International Menopause Society and the NAMS, North American Menopause Society, and also the Chinese Menopause Society, then all in all of these guidelines are lowest effective dose is recommended for the use in the MHT formulation. And the classification of estrogen and progestogen doses in the menopause hormone therapy, we classify the dose into three parts: the standard dose, low dose, ultra low dose. 2 to 4 milligram of oral 70 beta estradiol is considered to be standard dose. 1 milligram is low dose, and 2.25 and 2.5 milligram is thought to be ultra low dose. So these different dosages is chosen with the standardization of the patient get free of vasomotor symptoms. So we think the effective dose is to relieve the symptoms, relieve the menopausal symptoms from the patient. That is the effective dose. When the dose is achieved that function, the lowest dose is okay. It's okay for that patient. So the lowest effective dose is suitable for the patient during menopause transition and the postmenopausal. So estradiol, 70 beta estradiol 0.5 milligram plus derogestrone 2.5 milligram implements the lowest effective dose of menopause hormone therapy. So we conducted these mini femistone as a phase 3 clinical trial in China, and also these formulation have phase 3 clinical trial in Europe. So let's see the result of these clinical trials. So first, we see what the result in China. This is the protocol of the phase 3 clinical trial in China. After screen and sign of the informed consent and the recruitment, after the recruitment, the participants were randomized in 1-to-1 into 0.5 milligram of estradiol plus derogestrone 2.5 milligram and placebo. This will conduct for 12 weeks, and then after stop the medicine, then the follow-up days, 30 follow-up days. So altogether, we screened 560 volunteers, after screening, the randomized 332 did not receive study treatment in one case, and the the estrogen plus testosterone ultra dose is 166, and the placebo group is 165, and those who completed the study is 156 in each group. So this is the result. We can see the statistical difference in 4 weeks. So the severity, the primary outcome is the change in number of daily hot flashes during treatment. This in this fast group, then the difference could be seen in the 4th week, the 8th week, and also by the end of the study, the 12th week. So this also the result of the study. The mean number of flashes per day during treatment is secondary outcome. We can see the statistical difference in 8th week and also in the end of the treatment. Another secondary outcome is changes in MRI score and the Mancure score. These two are questionnaires for the menopause symptoms and the menopause quality of life. We can see the result. The differences between the treatment group and the control group, the placebo group, is statistically different. So the improvement in feeling down and action in muscle and joint pain. This muscle and joint pain is the top symptoms among the Chinese menopausal women, not the hot flash. Not we in Eastern countries, menopausal women, the symptoms is different from the Western countries. That the top symptoms in Eastern countries is muscle and joint pain, and the hot flash is about the ranking about the 4th or 5th the symptoms. So ultra dose estrogen plus testosterone was associated with improvements of feeling down and acting muscles or joints. So it is very effective in that aspect. So let's see the result in Europe. The protocol is slightly different. The study after recruitment and the randomization is 2-to-1. That is estrogen plus testosterone ultra dose, and the second group is placebo for about 12 weeks, and then change into the ultra dose estrogen plus testosterone. And the third group is the low dose, is 1 milligram of 70-beta estradiol plus 5 milligram of testosterone. So in Europe, the phase 3 study have 3 groups. Let's see the result. The efficacy of ultra-low dose estradiol phase 3 study. The mean change in the number of moderate to severe hot flashes per day from baseline to week 13 was similar in the 0.5 milligram estradiol plus testosterone 2.5 milligram, and 1 milligram estradiol plus 5 milligram testosterone. The efficacy of lowering down of the number of moderate to severe hot flashes per day is similar. And also, the changes in the placebo group was smaller and was significantly different to that in the ultra-low-dose group. So another result shows that a significant decrease in the total score corresponding to a reduction in symptoms was seen in all three groups over time, with a marked decrease at week 4 and a further decrease at week 13. Compared with placebo, there was a significant improvement with both ultra dose and low dose in the symptoms hot flash and sweating. Let's pull up of the two clinical trials in China and Europe. That's the data is pulled together, and the pulled data show that the two phase 3 trials, the ultra low dose group and the placebo group have different significantly from week 3. Change in number of hot flash per day from baseline to end of treatment was greater with ultra dose versus placebo in multi-ethnic population. Let's talk something about safety issue. The lower dose means more safety. So it's low dose is safe is very obvious. We can see here the result in China. That's the side effect considered to connected to the treatment was not significantly higher than the placebo group. The ultra low dose group was well tolerated with the occurrence of treatment emergent adverse effect being compared to placebo. The majority of the adverse effect was mild. Also, the ultra low dose group was well tolerated with the occurrence of the adverse effect being comparable to placebo. Also, the majority of the adverse effect were mild. The ultra low dose group was well tolerated with a good safety profile, and the majority of the adverse effects were mild. Of course, the bleeding occurred more frequently in the treatment group than the placebo. But you can see the results that the placebo group is also have some cases of unexpected bleeding. In the Europe phase 3 study, the bleeding or spotting was mainly mild, and the majority of women had no bleedings or spotting at any time during the study in both groups, both the low dose and the ultra low dose group. And the ultra low dose clinical trial in Europe, we can see a 1 year open label. It's after 12 weeks of RCT study, then the study shift to the open label study. This open labeled 1 year multi-center study in 446 healthy non-hysterectomized postmenopausal women with symptoms of estrogen deficiency. This is the protocol of the study. And the ultra-low dose group is, we can see the safe. This is the result of endometrial biopsy. That's no tissue, 3.8%, tissue insufficient to diagnosis, 32.7%, atrophic endometrium, 51.4%, secretory endometrium, 2.8%, and menstrual type endometrium, 1%, proliferatory endometrium, 7.6%, and simple hyperplasia atrophy, polyps, hyperplastic polyps without atypia, one case, 0.3%. So it's very low, no change, almost no change in the endometrium. So the endometrium safety is good. Ultra-low dose was associated with a favorable amenorrhea rate, and the majority of women were bleeding free for the duration of the study. This is a 1-year open-label study. And ultra-low dose was well tolerated among postmenopausal women, with no increase in treatment emergent adverse effects or severe adverse effects compared with placebo. It's comparable. And bone protection. If the estrogen dose is very low, does it still have bone protection effect? That is a question frequently asked from the patient. The FDA, Food and Drug Administration, approved the dose of estradiol for bone sparing as including the ultra-low dose, 0.5 milligram, and commonly used the low or ultra-low dose. The ultra-low dose estradiol treatment for 52 weeks, about 1 year, significantly improves bone mineral density in postmenopausal women with osteoporosis. That you can see in this diagram that estrogen group have increased the bone mineral density, while the placebo group no change. So the statistical difference is very significant. The p-value is lower than 0.001. So in summary, the continuous combined regimen of estradiol 0.5 milligram plus derogestrone 2.5 milligram implements in the lowest effective dose of menopause hormone therapy, which has been recommended by authoritative guidelines. The formulation of ultra-low dose can significantly reduce vasomotor symptoms of Chinese and European women and improve the quality of life of postmenopausal women. The formulation of estradiol 0.5 milligram, derogestrone 2.5 milligram demonstrated a good tolerability profile with a favorable amenorrhea rate and endometrial safety. The occurrence of adverse effects was comparable between treatment group and placebo group. The 0.5 milligram estradiol is the FDA approved dose for bone sparing, bone protection. Treatment with estradiol 0.5 milligram menopause hormone therapy regimen for 52 weeks can significantly improve bone density and achieve bone protection in postmenopausal women with osteoporosis. Thank you for your listening.
Thank you very much, Professor Shuhi, for your great presentation. It's very interesting to get your point of view from the other part of the world, I would say, and at least from my perspective. And we have also already received some questions, and I would like to start with my first question to Dr. Lee. So in our countries, women always prefer to get bioidentical hormones, so estradiol in combination with micronized progesterone, and it's really, really hard to convince them to take anything else. And we also have Tibolone on the market, but because it's synthetic, it's not very popular. So for me, it's very interesting to see that so many women in Korea actually use Tibolone. And I'm wondering if the discussion about bioidentical hormones is also starting or present, or is it not a topic at all in your country?
Thanks for the valuable question. I also wondered why Tibolone is so popular in Korea, and I think it's because our senior doctors used that medication, and we follow the medication. And actually, some studies revealed that the Tibolone use can increase the breast cancer risk, but I think there is some controversy in this data. But as I presented, there is a possibility of high stroke with the use of Tibolone. I think using more bioidentical hormone therapy would be further pursued in Korea. I agree. But still the culture in Korea is not changing so fast. So I presented the trend of Japan, and I think we should change our practice according to the evidence, I think.
Thank you. And this also brings me to a question from our audience, and I will just read it to you. So, hi, Professor Lee. I have a question for you, which confused me after your presentation. Both the IMS and FIGO claimed that Tibolone has an increased risk of breast cancer, and they recommend that micronized progesterone and dydrogesterone to be the safest option of MHT this year. But it seems that the results of the research from Korea is quite different. So what's your opinion on that?
It's in line with my previous answer. And I know that FDA did not permit the use of Tibolone in USA because of the safety issues, but in Korea, because the prevalence of Tibolone is so high, there is no less concern about the side effects, I think. But so I think the exact data on the side effects would be further evaluated by prospective multi-center study, I think.
Okay, thank you very much.
Yeah. May I say something about that?
Of course.
Yeah. The Tibolone is also very popular in China. Why was that? Because the Tibolone have some androgen-like effects, so they can increase the viability of the woman. They can treat the sleep disturbances. So the menopause woman is like that. That is very favorable of that medicine. And for the breast cancer issue, that I think the effect of Tibolone can actually stop the change of estrogen to estradiol in the breast. So actually, it can lower down the estradiol concentration in the breast, in that organ. So so by that effect, it seems that the tibolone can lower down the breast cancer rate actually. Well, in China, we use tibolone in very popular here in the tibolone. So, but we do not see any increase, any specific increase in the tibolone use group, than higher than other medications. So you see the question in the question is also asked about the micronized progesterone, right? The for the micronized progesterone is it's safe to the breast, it's okay, but for the in the published paper that said that the micronized progesterone may increase the endometrium cancer rate. So maybe it's a question of dose. The dose we use now is not enough to protect the endometrium, I think. So this is a need to be studied further. Yeah.
Okay, so thank you very much on your comment. And I have another question from our audience, and this is to Professor Shu He. So first of all, thank you for such a wonderful presentation. So to both of you, if 0.5 milligram is not available in our country and only 1 milligram is available, how can we best dose it?
Okay, you can simply cut into half. So it's 1 milligram is half pill. It is 0.5 milligram. So when we should start to use 0.5 milligram? Let's see, in our guideline that we to design sequentially the protocols in different ages, that if someone with 45 years old and already menopause come into your clinic, then after the examination, that's no contraindication, of course, that you can start to use sequentially estrogen plus progesterone with 2 milligram of estradiol. And when close to the 50 years of age, then you can change the regimen into 1 milligram plus progesterone, like dydrogesterone, sequentially used. And after 50 years of age, you can change into continuous combined therapy with 1 milligram of estradiol. And after 55 years of age, then you can change into the ultra-low dose formulation. If you do not have that formulation, you can just cut 1 milligram into half, and every half pill per day. So it mimics the ultra-low dose. And after 60 years of age, you can change the estrogen into the transdermal formulation. So this is what we do in China.
Okay, thank you. So before we continue with talking about dydrogesterone, I have another question for Dr. Lee. So you told us that the breast cancer rate or prevalence or incidence is higher in Korea and Japan in comparison to the other Asian countries. So do you have an explanation for that?
I think there will be some genetic differences among the ethnicities, I think.
Okay, but do all countries have like registries where the cancers are all nationwide registered? So that's everywhere the same.
You're right. Breast cancer is so the prevalence of breast cancer is so high in women. So many countries share their registry data, and
Okay.
in fact, the prevalence of breast cancer is definitely high in Korean society, and many think that there would be some genetic differences
Interesting.
can affect this situation, I think.
Okay, thank you very much. So now another question for Professor Shu He. So do Asian women need less HRT than Western women because of a diet with more phytoestrogens like soy?
Yeah, it's soil may contain the estrogen-like substances in the soybean, but I think when we regular intake the soil with meal, is completely no use for the relieving of the menopausal syndrome. You see, we have done some study of the so-called isoflavone, something like that. So when we take it, someone may feel some effect, but others do not. Why was that? The isoflavone, when taken into the body, they do not take effect itself. It must be changed into estrogen-like substances in the intestinal bacteria cohort. To change it into estrogen-like, but the bacteria, the intestinal bacteria is different from person to person. So some person have the bacteria can change into the estrogen, but others do not. So it's different from person to person. So we cannot expect the true effect of that substances.
Okay, thank you. So maybe another important question for you in respect to Turner syndrome. So is the low dose or ultra low dose formulation appropriate for women with Turner syndrome?
I think is the same for my answer in the first question, that we change the dose according to the age of the patient. If the patient is young, we use the 2 milligram, and then in 1 milligram, and then 0.5 milligram, and then after 60 years of age, we change into transdermal.
Okay, thank you. And maybe a final question for Dr. Lee. So there are a lot of questions about tibolone. So how often have you seen follicle growth while taking tibolone?
I don't think I had seen the situation, I think. I wonder why this question was if but the menopause is defined by the 1 year of cessation of menstruation, but it is there can be ovulation over 1 year, I think. So when in the process of menopausal therapy, some people are undergo abnormal uterine bleeding. I think many of them have some abrupt ovulation. So irrelevant of the medication, I think irregular ovulation can be occurred after the 1 year in some times, I think. So I don't know if tibolone can occur the follicular growth. I didn't experience that.
Okay. So thank you very much. So we couldn't answer all questions in the interest of time, but I thank you, first of all, to our two speakers for giving the presentation, for answering all the questions. And also thank you very much, the audience, for being with us and also to ask all these questions. And with that being said, I would like to invite you again for EMA School next weekend to Valencia next week. Thank you very much for being with us this afternoon, and have a great rest of the day. Thank you very much.
Thank you.
Bye-bye.
Good night.
Oh, good night.
Yeah, it's about 10 o'clock
Oh,
here.
yes. Okay, then
in China, in Beijing.
good night. Thank you. Bye-bye.